Welcome to today's office hours on the Menace cabinet, drugs that can mess up your gut. And we're going to be talking about the top 3 offenders, which do include antibiotics that mess up your gut microbiome, non-steroidal anti-inflammatory drugs, NSAIDs, so that would be drugs like Motrin, Aleve, Anacin, Advil, etc. These drugs damage your gut lining. And then finally, proton pump inhibitors, those potent acid blockers. And the typical proton pump inhibitor is Nexium, but there's Acifex, Prilosec, Protonix, several of them. These drugs do 3 important things in the gut, none of them good. They're very good at blocking stomach acid, which is why they're effective for people who have acid reflux. But let me tell you the flip side. The flip side of blocking stomach acid is you interfere with digestion, you mess up your microbiome, and you make yourself more susceptible to pathogens like viruses as well as others. So hang on, let me put on Do Not Disturb. My husband's texting me. Okay, we'll figure that out another time. So critically important that you understand all the mechanisms for how these drugs do damage in your GI tract, and also realize that this isn't a quick fix. Like you don't just, run to the pharmacy and buy a probiotic and you're good. So let's start with antibiotics because they really are at the top of the list. And I'll tell you that in my medical practice, I have gone from primarily treating conditions like Crohn's and ulcerative colitis, gallstones, colon cancer. I still treat a lot of inflammatory bowel disease, but for more run-of-the-mill things like gallstones, colon cancer, diverticulosis, constipation, to really spending a lot of my time and energy trying to reverse the damage from pharmaceuticals and the GI tract. And let me also say very clearly that as a physician, I'm thrilled that we have these potent pharmaceutical agents available to us, but we have to also acknowledge the flip side of these medications, which is they can have a really deleterious effect on the gut. So antibiotics, what is the problem with antibiotics? Well, think about the name, antibiotics, which means against bacteria. So there is no antibiotic out there which is only going to kill off the pathogen you're trying to treat and not also destroy droves of healthy gut bacteria. And as luck would have it, the helpful gut bacteria, the essential gut flora, are typically more susceptible to the antibiotics, more likely to be killed off than the pathogen. And of course, the more aggressive the pathogen, the more aggressive the antibiotic. So if you're, trying to fight a flesh-eating bacteria or something, methicillin-resistant Staph aureus, etc., you have to use a more potent antibiotic. As bacteria have gotten more resistant, primarily because of overuse of antibiotics, not just the ones we take, but the ones we unknowingly ingest in our food. About 80% of all the antibiotics used in America are used in the food industry. They're used as prophylaxis to prevent infections, for example, in dairy cows. They're used to fatten animals, etc. So even if you are very judicious about taking antibiotics, if you are eating food that is commercially grown, primarily animal products, you are also ingesting a fair amount of antibiotics, okay? So I want to be clear, there's no safe antibiotic. There's no antibiotic that is not going to damage your gut microbiome. That just does not exist. However, there are things that you can do to limit the antibiotic damage. And one of the first things is to make sure you really need that antibiotic. I've done lots of office hours on this. I have blog posts on this, but I can't emphasize it enough that the number one thing you need to do when you're prescribed an antibiotic is not to run and get a probiotic. And I'll tell you why that is a minimally effective strategy. The number one thing you need to do is you need to talk to whoever is prescribing that antibiotic, be it your gastroenterologist, primary care doc, OBGYN, nurse practitioner, and you need to say, is this antibiotic absolutely necessary? Okay? You need to be the kind of person who has one eyebrow raised and is like, do I really need this? Because you would be shocked at the amount of times an antibiotic is not actually necessary. They might be treating something that they're pretty convinced is a viral infection, but they're giving you an antibiotic just in case. And, there's a lot of CYA that goes on in medicine. And when your ENT doc ruins your gut because they're treating maybe strep, it's not their problem that your gut is ruined. It's my problem. So don't make problems for me. So again, everybody, medicine, we are in our little silos and we are very focused on, what we need to do within our specialty. So in my specialty as a gastroenterologist, I'm really concerned about protecting your gut, right? And I am, your sinus infection, it's not that I don't care, but I'm like, maybe you just need to suck it up a little bit. Or, are you sure this is even a bacterial infection? So again, through my GI lens, and I cop to this, I'm more concerned about preserving your gut for the long term and the short term than the fact that an antibiotic may cut down the course of your sinus infection by a few days. Now, if you have a sinus infection that's not going to resolve on its own without antibiotics, of course, I would like you to treat that. But that is the exception rather than the norm. Okay, so it's really important to realize this, and I think this is a nuance that you don't always get if you're not a physician, that I really want to share with you, which is that people practice very defensive medicine. Your ENT wants to relieve your sinus infection when you go to see them for a sinus infection. That is their main concern. The fact that they're going to kill off a lot of your gut microbes, and this may worsen your irritable bowel syndrome, this may trigger an autoimmune disease, this may create dysbiosis with a lot of gas and bloating and symptoms down the road, not their problem. Again, that's my problem. So, it's not that doctors aren't aware, they don't read the literature, etc., but it's that they're singularly focused typically on solving a problem within their specialty. So that's where you come in as a well-informed advocate for your overall health, and you say, I appreciate that you're trying to solve this problem I have with a sinus infection, and I'm really uncomfortable and I would like relief, but what else can I do besides an antibiotic? And again, I want the words to come out of your mouth. Is this antibiotic absolutely necessary? And then there's a whole, in my new book, The Antiviral Gut, and in my second book, The Microbiome Solution, I have the whole list of questions to ask about a more narrow spectrum antibiotic, about limiting the time you're on the antibiotic, about, checking culture results, waiting and, watchful waiting, etc. So I go into detail about all of that, but I literally feel like I cannot say it enough that it is, trying to take a probiotic or even, fermented foods and all of these things we do to rehab the microbiome after antibiotics are not going to bring you back to where you were before in the vast majority of cases. Okay, so again, the most important thing is judicious use of antibiotics. Dr. Marty Blaser, in his amazing book, Missing Microbes, which was written a long time ago, over a decade ago, he is an infectious disease specialist, used to be chief of infectious diseases at NYU. I'm not sure if he still is, but he's done a lot of research on antibiotic damage. And in his book, he writes about the fact that a 5 to 7 day course of antibiotics, broad spectrum antibiotics, can remove up to a third of your gut bacteria. And the example I like to use, and those of you who follow me on social media have heard me talk about antibiotics before, are probably aware that I liken taking a probiotic to, after you've taken an antibiotic, to filling a bathtub full. You take the antibiotic, you drain out the water, you take a glass, you pour a glass of water back in, that's a probiotic, right? You're not going to get back to a full bathtub. And this is particularly important. I don't mean to be all doom and gloom, but what I want to tell you is the decision about taking an antibiotic is a very personalized one. And it's based really on two factors. So when I see a patient in my practice and they're contemplating an antibiotic, whether it's one I'm prescribing, rarely, or one another doctor is prescribing and they're coming to talk to me about it, there are two really important factors that I'm considering. The first factor is, do they actually have an infection? And if they do, how severe an infection is this? Okay, so what are we treating? Number one. The second important factor is, what is their background noise? What is their own history of dysbiosis in terms of, I go all the way back to birth. Were they born vaginally or C-section? Were they nursed? Did they take a lot of antibiotics in childhood or in their adult years? What has their diet look like? Are they on other microbiome disrupting drugs like proton pump inhibitors, etc.? So I look at the sum total. Do they have an autoimmune disease? Have they had a previous episode of Clostridial difficile infection or another antibiotic associated diarrheal illness? So I take all of these things into consideration, and I'm literally like, okay, you get a point for this, a point for that. I'm totting it all up. And then I'm weighing the risk versus a benefit of this antibiotic. And again, two important factors. What is the infection we're treating? What is their history in terms of how high a risk are they at dysbiosis or an antibiotic, a more acute antibiotic associated diarrhea? So that's a process in my mind. And then, if I'm prescribing the antibiotic, I'm going to, make a decision based on that. If I'm advising them. So for example, a common question I get from my patients is, I have a history of mitral valve prolapse, which is a common heart abnormality. And the dentist says I need to get antibiotics whenever I come in for a cleaning. Wrong. That is not the recommendation anymore. That was a recommendation years ago, but the current recommendation is you do not need antibiotic prophylaxis if you have mitral valve prolapse. I see people in my office who have been getting antibiotics every time they go to the dentist for decades, and maybe they're going to the dentist 2 or 3 times a year, times 30 years. That could be 90 courses of antibiotics for something that we now know is unnecessary. So even these brief antibiotic exposures can add up, and they can add up to significant damage in your gut. Okay, so antibiotics, number 1. Proton pump inhibitors are probably as big a problem as antibiotics. And a study from one of our GI journals, Gut, several years ago showed that prolonged exposure to proton pump inhibitors, so over about 2 months use, so beyond the 6 to 8 weeks that you would use, for example, for an acute ulcer or gastritis, so the more chronic proton pump inhibitor use, over time was associated with a microbiome that was just as messed up and disrupted as if you'd been on long-term antibiotics. That's crazy, right? And what they found was, the whole thing, and let me back up and say that proton pump inhibitors are disruptive to the gut in 3 important ways. The first is that they block stomach acid, and stomach acid is an integral part of digestion. It's digestion 101. I'm going to come back to that. I'm going to jump ahead to the second thing they do, which is they mess up the microbiome. How do they do that? They are not bactericidal the way antibiotics are, meaning they're not directly harmful to the majority of your gut bacteria. But your gut microbiome has a really important gradient. As we go from north, the mouth, to south, the anus, in the GI tract, the amount of gut bacteria increase dramatically. So actually the mouth has a fair amount of gut bacteria, but as we go primarily from the esophagus, stomach, small intestine down to the colon, mouth is a fairly dirty organ, as we say. But the upper part of the GI tract, the esophagus, the stomach, the first part of the small intestine, the duodenum, and the later parts, the jejunum and ileum, all have a lot less bacteria than the colon. And that is on purpose. That's because we're seeing active digestion in the upper part of the digestive tract. Like, for example, in the stomach, we see a lot of enzymatic activity. Also in the duodenum, we see a lot of absorption of fat, of protein, of carbohydrates. Lower down in the colon is where we see the fermentation. So that's where gut bacteria, for example, take all that great plant fiber you're eating, they ferment it into short-chain fatty acids, which are important for the health of the gut lining and for modulating and guiding our immune system. So just as different parts of the gut lining are specialized in terms of what they do, the esophagus lining does one thing, the stomach lining does another thing, and they're different cells. For example, in the esophagus, we have squamous cells rather, and in the stomach we have columnar cells. The columnar cells in the stomach are very resistant to acid. The squamous cells in the esophagus are not, which is why when you have acid reflux and your esophagus is constantly bathed in acid, that can put you at risk for inflammation as well as cancer of the esophagus, because the cells are not designed to be seeing acid all the time like the stomach cells. So we have specialized cells, we have different areas where things get absorbed. For example, low down in the small intestine, in the ileum, is where B12 gets absorbed and where bile salts get recycled. So every part of the GI tract is different, and it's important. It's like different parts of our body, right? Our fingers do different things from our elbows, do different things from our feet and knees and hips and liver and kidneys. So even within an organ like the GI tract, there are very specialized functions. So again, back to proton pump inhibitors microbiome. So we have this gradient from north to south in the GI tract where we go from low levels of bacteria to high levels of bacteria. And that is essential for digestion. It is essential for the absorptive process, for the enzymes to work, for the fiber to get fermented, etc. Stomach acid is a part of maintaining that normal gradient. And when you block stomach acid, now you tend to get disruption of that gradient. Now you have more bacteria in the upper part of the GI tract and sometimes less lower down, but you don't have a natural gradient from low to high. Now it's sort of high, medium. And what can happen as a result of that, and in that study that was published in the magazine Gut, in the journal Gut, what they saw in people taking these proton pump inhibitors for longer than a few months, they saw, for example, mouth anaerobes that are supposed to be limited to the mouth were now in the colon. That's a bad sign, right? It's like global warming. When we start seeing mouth anaerobes in the colon, not good. And they concluded, the researchers, not my conclusion, the researchers who studied this, that long-term proton pump inhibitors were as bad for the gut as long-term antibiotics. All right. And I did a post earlier about reflecting on stomach acid this holiday season and nudging a friend, a loved one, a family member, a colleague who you know is taking a proton pump inhibitor and just saying, hey, I don't know what you're taking this for, but I've been reading a lot. I've been hearing a lot. This integrative gastroenterologist I follow has been talking about the dangers of taking these drugs long term and how they can mess up digestion, make you more susceptible to pathogens, etc. So maybe a good idea to talk to whoever's prescribing it or recommending it about whether you really need it. Okay, so I am like a crusader about these drugs. Why? Because my colleagues hand them out like water and they're really bad for the gut. So again, that is how they mess up your microbiome. Let's talk about the other two things that stomach acid blocking drugs like proton pump inhibitors do, which is interfering with digestion and making you more susceptible to pathogens. I want to also clarify here that by acid blocking drugs, I'm talking specifically about proton pump inhibitors. I'm not talking about H2 blockers like Pepcid, Zantac, etc. Zantac has other problems in terms of carcinogens, but and I'm not talking about, again, antacids. I am talking about proton pump inhibitors, Nexium, Prilosec, Acifex, Protonix, etc. There's a whole slew of them, and they all have the same mechanism. So what do? They shut down the acid pump in your stomach. It's called a proton potassium ATPase, and they basically just lock that down. And so they're really good at their job, right? Which is why they're so popular. They block stomach acid. And when you are not having a lot of excretion or any excretion of stomach acid, what that means is that when you overfill your stomach by eating a big high-fat meal late at night, and normally that lower esophageal sphincter would pop open and acid would come up to your esophagus, making you feel bad on purpose, giving you that important feedback that, hey, not good. You don't have that. You're still having the valve opening, but you're not having acid coming up. You're not having symptoms. So you're like, great. I can have a cheeseburger at 11 o'clock at night or 4 slices of pepperoni pizza or whatever it is you're having, and I don't have any problems. This is fantastic. But what I want to remind you, and I know you guys know because you're well informed, but tell your friends, I want to remind you that these negative symptoms we experience, symptoms like heartburn, are less a medical disease and more an important feedback loop to keep us healthy, to sort of remind us that eating a high-fat meal late at night, overfilling our stomach, these things, too much coffee, too much alcohol, too much caffeine, coffee, too much alcohol, too much caffeine, smoking, chocolate, unfortunately, all of these things can open up the lower esophageal sphincter. Why is a fatty meal such a problem? Because of the macronutrients, fat, proteins, carbohydrates. Fatty foods are the most difficult to digest and they take the longest. So when you eat a fatty meal, let's say you eat some pork rinds. I don't know why you would do that, but let's say you lose your mind and you eat some pork rinds. I think pork rinds rank up there with soda as things that I just would advise against. But let's say you eat some pork rinds and your stomach immediately, the chemoreceptors, the chemical receptors in your stomach sense, ooh, high fat meal. They send a signal to something called the gastric pacemaker, which is a little bundle of nerves at the top of the stomach. And they say, whoa, slow down, we got fat on board, this is gonna take a while. And so the gastric pacemaker decreases the normal contractility of the stomach by a couple beats per minute. And that means that the stomach is going to stay full longer. And that's why fatty foods make you feel full. They increase satiety because they slow down the emptying of your stomach. Once your stomach empties, you're like, oh, I feel hungry again, right? So if you're eating something with a lot of fat, you're gonna feel full longer. And that can be helpful actually if you are trying to lose weight and you are trying not to eat all the time. I certainly wouldn't recommend you do it with pork rinds, but whether it's avocado or nuts or things like that that have a higher fat content, fiber can do it also. So a big salad, an apple, all of those things, eating high fiber, high fat will make you feel full longer. Fiber doesn't slow down the emptying of the stomach like fat does though, okay? So that's why high fat meals are a problem. Eating late at night, why? Or even eating at night, because your stomach has a bedtime. The contractility of the stomach is also tied to the circadian rhythm, the light-dark cycle, which means that as the sun sets, which where I live in Washington, D.C. is late. It's probably 4:47 today, 5 o'clock. It means that once it gets dark, stomach contractility slows way down. And so if you're eating your largest meal after dark, you are also setting yourself up for reflux, right? So again, the symptoms that you get of heartburn are a reminder, hey, eat earlier in the day when the stomach is more active, when you actually need the calories. Most of us are in repose after the sun sets. We're probably not needing to, consume 800-900 calories. So that is, again, just sort of explaining that feedback loop. So let's, again, focus a little bit on digestion. What does stomach acid do? Well, it provides the optimal pH for the nutrients to be absorbed and assimilated. It provides the optimal pH for the digestive enzymes to work. The stomach acid itself stimulates peristalsis in the gut, and it also releases stomach acid is also something that needs to happen for the pancreas and other digestive organs to do their job properly. So without stomach acid, you are not going to be able to digest food properly. And that's just a fact. So if you are taking a proton pump inhibitor on a daily basis, or maybe even twice a day, and blocking stomach acid, you have to be aware that you are interfering with digestion. In the short term, we don't see a lot of problems from that, but in the long term, when we get into the situation where you've been on a proton pump inhibitor for months, or sometimes years, or sometimes decades in the patients I see, then we run into problems. And we run into a wide range of problems because basically the majority of organs in our body are dependent on the delivery of nutrients for them to function properly. So our brains. So we see studies showing decrease in cognition in people taking proton pump inhibitors long term. We see an increase in cancer, particularly cancer of the stomach, in people taking proton pump inhibitors long term. We see kidney problems. We see bone problems. We see an increased fracture risk and osteoporosis because, again, you're malabsorbing some important nutrients, fat-soluble vitamins like vitamins A, D, E, and K, etc. So that's why, the results are so, the sort of results of fallout, the side effects are so wide, cognitive decline, cancer, bone loss, etc. So there are situations where you need to be on a proton pump inhibitor long term, but they are pretty rare. I'll tell you, I've been a practicing gastroenterologist for over 25 years, and I can count on one hand, with fingers left over, the amount of conditions that require a long-term proton pump inhibitor. I'm going to say that again for you. I have been a practicing gastroenterologist for over 25 years, and I can count on one hand and have fingers left over the different conditions that require you to be on a long-term proton pump inhibitor. So what are they? Barrett's esophagus, which is a premalignant condition of the esophagus, but not just any Barrett's esophagus, long segment Barrett's esophagus, where you have more than a couple centimeters of esophagus replaced with this potential premalignant lining. So Barrett's esophagus, Zollinger-Ellison syndrome, where you have overproduction of stomach acid, refractory gastroesophageal reflux disease, which means you've tried everything and failed. Non-healing stomach ulcers is probably one or two that I have missed. But even a non-healing ulcer, that's not going to last for years. If you have an ulcer in your stomach that hasn't healed after a couple years, that's really concerning for stomach cancer. So ulcers heal. They either heal on their own, or they heal with the help of a proton pump inhibitor, or they heal with the eradication of Helicobacter pylori, a bacteria that can be associated with inflammation in the gut. But they don't just stick around for years. So if you were treated with an acid blocker, like a proton pump inhibitor for a stomach ulcer, you need to follow up with your gastroenterologist and say, hey, what's going on? Has my ulcer healed? Like, you need to rescope me and tell me if this is healed. Don't just keep me on this drug perpetually, right? Okay. What else? Susceptibility to pathogens. So you all know about my new book. Where is it? I should have it here beside me, but I don't. It's somewhere behind me on the bookshelf. The Antiviral Gut, Tackling Pathogens from the Inside Out. And one of the chapters in that book is host defenses. Wait, I have to grab the book. Hold on. All right. My publishers at Penguin Random House would not be happy for me to miss out on an opportunity to plug my new book, The Antiviral Gut. And you know what? It's a really good book, I have to say. I worked really hard on it. It took me over 2 years to write this book. And one of the chapters in here is on host defenses. Okay, so it's chapter 3. I'm going to just turn to that chapter for a little dramatic reading. And I start each chapter with a quotation. And the quotation for this chapter by Franz Grillparzer is, "What seems insignificant when you have it is important when you need it." And I think that is describing stomach acid to a T. So again, in this chapter, I talk all about stomach acid. And I start with a story from nearly 600 people sickened during a Royal Caribbean cruise to the Caribbean. Their vacation was no day at the beach, pun intended. About a fifth of the 3,050 people aboard Explorer of the Seas, which left Cape Liberty, New Jersey, for a 10-day cruise in January 2014, came down with an illness. People were vomiting into bags, into buckets, or on the floor of the ship's infirmary. The 50% refund, an additional 50% future cruise credit, seemed like chump change compensation for the days of misery, holed up in cabins with stomach cramps, vomiting, diarrhea, and malaise. Now, if you weren't listening carefully, might have thought this was COVID, but this was 2014. This is almost, this is several years before COVID, before, a first case of COVID, whether you count that as 2019 or 2020, several years before. So what I'm talking about is norovirus. That norovirus episode was, at the time, the largest viral outbreak ever reported on a cruise ship, with 1 in 5 aboard coming down with a highly contagious virus, which spreads by contact with infected people, contaminated food, water, or surfaces. There are more than 20 million cases of norovirus every year in the United States. Only the common cold is more frequent. And as is true with most viruses, its sweet spot is small spaces with lots of people. But here's a conundrum. Common areas in cruise ships are crowded. So when hundreds of people are spewing gazillions of highly contagious viral particles everywhere and contaminating most of the surfaces, why do only a fraction of the other passengers get sick? The average stateroom on a ship is about the size of a master bathroom. But even for 2 people sleeping in the same cabin, not uncommon for one person to become infected while the other one doesn't. Clearly, exposure alone doesn't tell the whole story. Certain people just seem to be more susceptible to viruses. And then I go on to talk about what makes you more susceptible, immune system, etc. And then I get into why blocking stomach acid makes you more susceptible. And obviously in the book I go into more detail, but let me give you the cliff notes here. Stomach acid unravels viral protein. kills viruses. It's weird to say kills because viruses aren't necessarily alive until they infect you, but it inanimates an already inanimate object. It unravels a viral protein so that the virus cannot infect you, okay? And no, that's not foolproof. It doesn't mean if you have stomach acid, you're never going to get COVID. I mean, we've seen plenty of people walking around with intact stomach acid who got COVID, but it decreases the chances because when you don't have stomach acid, then that viral protein isn't unraveled and it can infect an intestinal cell and get into the body that way. And we know the GI tract is a common portal of entry for viruses like SARS-CoV-2, like norovirus, like rotavirus, lots of others. And that's why we see GI symptoms, not just with those GI viruses like rotavirus, but also with SARS-CoV-2. So in a large population-based study from 2020 that was done here in the US, they saw that people taking a proton pump inhibitor once a day had double the likelihood of testing positive for COVID. And people taking an acid blocker twice a day were 3 to 4-fold more likely to come down with COVID. So that's a big increased risk, right? And it's really for that reason. But it's not just viral illnesses. We see an increased risk of Clostridial difficile infection, a bacterial infection that's associated with antibiotic use. Basically, any enteric pathogen, any pathogen that can infect the gut, we see an increased risk. So foodborne illnesses, salmonella, campylobacter, etc. And we've known about that for decades. So, you know, it was part of my main inspiration for writing the book was when that study came out. I said to my husband, so you know blocking stomach acid would increase your risk for COVID, right? And he was like, no, I'm a counterterrorism expert. I didn't know that. So then I asked some of my doctor friends, my friend who's a dermatologist, another friend who's an ER doc, and they were sort of like, you know, makes sense, but I wasn't aware of that. And then I asked some of my GI colleagues, and they also were unaware. So I thought, okay, people really are not aware of this, even medical professionals. So this is, you know, this is the kind of information I need to share with people. So, you know, the antiviral gut 2 years later, obviously not just to talk about stomach acid, but really important for us to understand these host defenses. And so some of the host defenses we've covered have been the microbiome and stomach acid. And now I want to turn to the gut lining and non-steroidal anti-inflammatory drugs. And after this, I'm going to stop talking and answer some questions. So non-steroidal anti-inflammatory drugs. I just happened to find this Aleve. We don't have a lot of drugs in our house, but I somehow cannot get my husband off of non-steroidal anti-inflammatory drugs altogether. We are aging athletes in this household, and sometimes when we run long distances and oversport ourselves, as my dear departed mother-in-law would say, sometimes we get knee pain and other things hurting. And so while I'm always recommending just, you know, go play some chess and rest and ice, etc., sometimes, you know, he does pull out an Aleve. And I'm always telling him, you know, that can cause fatal GI bleeding and other things. And it can. It's not the most common side effect, but one of the most common side effects is that these drugs damage the gut lining. They increase the intestinal permeability. And we know that increased intestinal permeability increases the likelihood of a virus that is in your body penetrating that gut lining, getting into distant organs, etc. So when we look at conditions like MIS-C, multisystem inflammatory syndrome, in children, or even multisystem inflammatory syndrome in adults, what we find is that this sort of prolonged form of the viral infection is associated with an increase in something called zonulin, which is a marker for an increase in intestinal permeability. So we think that is one of the mechanisms for multisystem inflammatory syndrome. It's not the only one, but one of the associated mechanisms. So, you know, this is not the only thing that damages your gut lining. Alcohol, stress, parasitic infections, radiation, there are lots of things that can do it. But when I do upper endoscopy and I see an ulcer in the stomach or in the duodenum, that's just a larger version of an increase in intestinal permeability. That's an actual hole that these drugs have created in the gut lining. they create microscopic versions of that, and I might not see that, but that is manifest as an increase in permeability. The little pores in the gut lining become bigger, and when that happens, it can allow things to get into the body, like viruses, etc., like undigested food particles, lots of different things that shouldn't be there. And I did one of these on leaky gut in the past. I can do another one. You guys let me know what you want to hear. So with that, I'm going to stop. And again, just to summarize, the Menace cabinet, let me say again, I am delighted that we have all these pharmaceutical tools at our disposal, but we need to use them judiciously. Antibiotics, proton pump inhibitors, NSAIDs, top 3 offenders. Antibiotics remove large amounts of gut bacteria from your microbiome, cannot be replaced by just taking a probiotic. Proton pump inhibitors interfere with digestion, mess up your microbiome, and make you more susceptible to pathogens. And finally, non-steroidal anti-inflammatory drugs, deleterious to the gut lining. All right, I'm going to stop there and look at some questions. Thanks so much for joining me. All right, so what do we have? We go all the way to the top. All right, give me a sec as I scroll through these. Hi, I need help with scar tissues in my stomach. So not sure what you're referring to here. If you're referring to scar tissue on the outside of your GI tract from previous surgery or an accident, or scar tissue in your stomach lining, which would most likely be the result of an ulcer. So you need to specify a little for me, because very different approach. Scar tissue from an ulcer, for example, on the inside of your gut lining is handled very differently from scar tissue on the outside of your intestines, which is usually a result of previous surgery. And that can cause something called adhesions, where the gut kind of sticks in different places where it shouldn't, and can cause abdominal pain, bowel obstructions, etc. And while there are a lot of techniques that we use for avoiding those bowel obstructions, sometimes when they get to the point where they're recurrent, we have to recommend additional surgery to remove that scar tissue. So again, 2 sort of separate pathways. All right, what else do we have? Is chlorophyll good for your gut? If yes, which is best, liquid or tabs? We don't have scientific evidence that taking a chlorophyll supplement is doing anything for your gut, but we have tons of evidence that eating foods that are high in chlorophyll, which are basically, green foods, particularly some of the sort of grassy things, are very good for your gut. For example, watercress is one of those that's high in chlorophyll that's good for your gut. Okay. And I'm always going to tell you, even if I'm recommending a supplement to you, I'm always going to tell you that food is the better choice, right? So if I'm telling you about a study of looking at turmeric in patients with ulcerative colitis, and that this study found that the turmeric was as effective as one of the medications for ulcerative colitis, I'm going to tell you, get some turmeric root and use that, or a turmeric spice, over a pill, because the pills typically have other things in them and they're not always as bioavailable. The supplement manufacturers will tell you the opposite, but that's not actually true. Okay. All right, what else do we have here? All of you fantastic people. Park City Julie says, we need to be our own advocate. Brava, Julie, I couldn't agree more. And, I hate to sound negative about the medical profession. I'm a proud physician. My father's a physician. He's a retired orthopedic surgeon. My brother is a physician. He's a spine surgeon. I consider it an incredible honor and privilege to care for patients. I'm reopening my medical practice in another week or 2 after being closed to new patients for the year. And I couldn't be more excited. I'm also renovating the office, which is super exciting too. But I couldn't be more excited because I do consider it a calling. But at the same time, I think we have to be eyes wide open, and we have to appreciate and acknowledge that there is commercial bias, that people are incentivized financially to do things a certain way, that people don't always have the time, physicians, to explain, to consider all these different things. And so you have to be your own advocate. And you have to ask these questions. And you'd be surprised how many times a doctor's like, oh, you don't want an antibiotic? Oh, that's no problem. This is really very likely to be a viral infection anyway, okay? So couldn't agree with you more, Julie. Greetings from Frankfurt, from Marija Makarska. Marija, I'm not sure if I'm saying your name correctly, but let me tell you all the German I know. Ach, es ist mir zu kalt heute Abend, and hast du Schokolade dabei? So you send me a message and tell me if I said that correctly. Auf Wiedersehen. You guys are so fun. I love you guys. Okay. Rosa wants to know, how can I schedule an appointment with you? I searched on the Gutless website and couldn't find information. You are right, because we are in the process of redoing the website. So give me about a week or two. I promise you, by the second half of January, when you go to the robinchutkan.com website or the gutless.com website, there'll be a whole page there called Medical Practice with tons of information. I've been working on all the updated forms and everything this morning with all the updated information, how to become a patient and how to, create a profile in our portal, etc. And I look forward to meeting you. And the good thing is I'm going to be offering appointments both in person and virtually. So I'm really excited about that. The Southern Mother, how else to treat a flare-up? Southern Mother, tell me, a flare-up of what? A flare-up of acid reflux, colitis. We've talked about a couple different things, but I want to answer your question. So tell me a flare-up of what you're talking about. Shashi says, checking with physician if mandatory to take antibiotic. Yes, do it. And push those doctors. Danny Banger 24 wants to know, so what's the solution if probiotics aren't the answer? Such a good question, Danny. And I have a whole other book called The Microbiome Solution to tell you the answer, because it's not a one-word answer, but there are dietary things, there are lifestyle things, there are even, mental things that you can do. But some of the dietary things involve, not surprisingly, eating a lot of plant fiber, also including some fermented foods like sauerkraut and kimchi. There's mushroom teas that you can make. There are other things you need to limit. So it's fairly comprehensive. Microbiome Solution gives good tips. And in this new book, The Antiviral Gut, I also have a whole section on rehabbing the microbiome and what to do if you've been on antibiotics, okay? Considering removing your gallbladder. Don't do that till you talk to me. I have an appointment with the surgeon tomorrow. Any advice taking the big step? Yes. So the first thing you need to ask is, why do you want to remove my gallbladder? Is it for, I'm assuming it's not for gallbladder cancer. That's really rare. If it's just for gallstones, know that changing your diet and decreasing the fat in your diet can resolve that problem, okay? So that's the first thing I want you to know. If you have gallstones that are getting stuck in one of the valves of the pancreas or the liver or something there, that, the valves that drain, the ducts that drain the gallbladder, and things are getting stuck, there are endoscopic procedures you can do. There's something called an ERCP, an endoscopic retrograde cholangiopancreatography. It's a mouthful, an ERCP, that can remove those stones. And sometimes they can put a stent in, like a little, literally like a little metal straw to keep that duct open and keep it from closing and getting blocked again. Now, surgeons, here's a little secret, little inside information. Surgeons don't do ERCPs, gastroenterologists do. So a surgeon is typically not going to say, yeah, I don't need to take out your gallbladder. Go see my GI colleague and they can do an ERCP. They're going to tell you about what they do because that's how they make their living, right? So what I would recommend is, before you commit to this, go and also see a gastroenterologist and ask about an ERCP and whether that is advisable. Now, if you are not having episodes of acute cholecystitis, which mean acute inflammation of the gallbladder, but you're just having symptomatic cholelithiasis, I know there's a lot of technical jargon, symptoms from it, that's an even lesser indication. Let me remind everyone listening also that I'm not giving you medical advice. This is simply for educational and entertainment purposes. Very entertaining, hearing about poo and gallstones, right? And so, again, not medical advice I'm giving you here. I'm just giving you some educational information to help you be a better advocate with your doctor. All right. How does alcohol affect the microbiome? Such a great question, Nicole, and I neglected to mention that here, but I did do an office hours a couple weeks ago on alcohol, and I have this wonderful person working with me now, Noah Rosenzweig, and he is helping me do things that I don't know how to do, or that I'm not good at. So Noah's helping me, for example, and he'll be watching this, so he'll laugh, but make some clips of the office hours, you know, some shorter replays. Not everybody wants to wade through an hour's worth of me jabbering. So he's doing some reels that are clips, like summary things. You may have seen one of them. We did one on the virome. It was like 5 facts about the virome. So he did one on alcohol that will be up soon. And it was just, you know, short little, it's less than a 60-second reel, but short clips that summarize it. But if you want to go into all the details about how alcohol affects the microbiome, check back for that alcohol office hours a few weeks ago, okay? But what I want to tell you is that before we had antibiotics, we had alcohol. That was how we killed microbes. And when you go to get your blood drawn, they still use a little alcohol swab on you, right? To clean off the skin, to kill microbes. So alcohol is also bactericidal. It also kills gut bacteria. And alcohol, so it can affect the microbiome. It can also affect production of stomach acid. It can cause inflammation in the stomach. It can interfere with digestive enzymes. It affects the liver. It can harm the gut lining. It can do a lot of things. So this is an area where really, again, thinking about what the background noise is. If you already have a very inflamed or diseased gut, I would say no alcohol. And for everybody else, you know, you have to think about personally. Are you the kind of person where when you drink, you tend to drink too much? What does moderation look like to you? Maybe none is easier than some, etc. But I go into all of that in that last office hours. All right. What else do we have from you fantastic folks? Danny's sticking around for the solutions. Can allergy drugs have side effects? Yes, yes, yes. So antihistamines are very drying, not just to the nasal passages, but to the GI tract. So one of the common side effects we see with antihistamines is constipation. Okay, and they can